Okay, sorry, there is something. Something wrong. Yeah.
Got it. Experts here.
So a very good evening to all of you. And I, on behalf of the Indian Society of Cornea and Cataract Refractive Surgeons, welcome you all in this webinar on, a lecture. It's basically a lecture from one of the masters in the field of cornea and refractive surgery. And the topic is cornea clinical practice. We have with us our president of ISCRS, Professor J.S. Titial, who is the chief and professor of ophthalmology in the Cataract, Cornea and Refractive Surgery Services at RP Center, AIMS. He has numerous publications, many awards, including all international as well as national awards. He has numerous orations to his credit, and almost from every state of this country. And he was the first Indian to perform live cataract surgery at the ASCRS, and the most coveted Padma Shri, which is the award which people would really love to have it. He got it from Government of India by the President of India, and that's a great honor, not only for him, but also for ISCRS. So we welcome him in this webinar. We also have with us our Vice President, Dr. Rishi Mohan, who has got his training again from RP Center, his specialty training, and then went on to do his FRCS and also a fellowship at Windsor, UK in 1994. He has received numerous awards right from his undergraduate days and postgraduate days, and then he has held various positions, which includes the positions in the Delhi Ophthalmological Society as well as the All India Ophthalmological Society, Eye Bank Association of India, and of course, he is the Vice President of ISCRS. We welcome him in this webinar. We also have with us Dr. Rajiv Mukherjee, who will be joining in a short while, in a couple of minutes from now, who is the Treasurer of ISCRS and Director and Senior Consultant at Mukherjee Eye Clinic in Delhi. He is Visiting Professor at Feinberg School of Medicine, Chicago, USA, and established cornea and phaco surgeon, and is very much actively involved in academics. We also have with us Professor Namrata Sharma, who is the Chairperson of ISCRS, Chairperson Scientific Committee of ISCRS. She is also the Secretary of AIOS and Eye Bank Association of India, and the Regional Secretary, APAO, and Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery, with loads of publications and awards to her credit. Our speaker today is Dr. J.K. Reddy, who is the Chief Cornea Clinic, Director Technical at Sankara Eye Center, Coimbatore. He is vastly experienced in terms of academics as well as in terms of surgeries as well as innovations. You can see the number of cataract, cornea, and refractive surgeries that he has done. That is huge in number. He has presented in almost every part of the world, in all the international and the national meetings, and is known for his novel innovations in the field of intraocular implants, corneal cross-linking, and various other corneal and cataract procedures. So we welcome Dr. J.K. Reddy in this webinar. Amongst the expert panelists, we have Dr. Amit Gupta, who is a professor in the field of cornea, cataract, and refractive surgery services at Eye Center, PGI, Chandigarh. He's also the Senior Vice President of Chandigarh Ophthalmological Society, and he is very much interested in the field of and contact lenses. He has been invited for talks in many national and international conferences and has numerous publications to his credit. So we welcome Dr. Amit Gupta. We also have with us Dr. Shakeen Singh as an expert panelist, who is the director, Dr. Shakeen's Eye Hospital and LASIK Laser Center, Amritsar. He has done his training from Government Medical College, Amritsar, and then now he is professor and head Department of Ophthalmology and Dean Academics and Faculty, Sri Guru Ram Das University. He is also the ex-president of Punjab Ophthalmic Society and joint secretary of Ocular Trauma Society of India. He is North Zone representative of Eye Bank Association of India and NABH assessor and chief editor of Tropical Ophthalmology. We welcome you, sir. And myself, I'm Dr. Rajesh Sinha, working as professor in the Cornea, Lens and Refractive Surgery Services at RP Center AIMS and the Honorary General Secretary of ISCRIS. So on behalf of ISCRIS, I welcome you all in this wonderful webinar wherein we will be having lecture from Dr. J.K. Reddy. Before we actually start his lecture, I request the President of ISCRIS, Professor J.S. Tityal, to say a few words.
Yeah, thank you very much, Rajesh. I think the initiative which ISCRIS has taken in the right direction to actually not orient ourselves, but orient the entire community on our basics and the expert requirement for expertization of our colleagues is very, very important. And to see that today we have Dr. J.K. Reddy, who's a very close friend of ours, world-renowned personality in the field of cornea and refractive. And I understand and I believe and I've seen him showing the innovations which many of us had seen that, and we are very proud of his achievements also. And it will be great to listen to him today, and we'll be definitely learning many, many things. Also, I know that viewers who are logged in today will also have a lot of queries, which I'm pretty sure he'll be very happy to answer those queries also. Thank you, JK, for agreeing to deliver this lecture today, and we can start now.
So innovations, many of us are.
Yeah, I thank for this invitation to such a organization and kind words from Dr. Professor Rajesh Sinha and Professor Jeevan Tityal sir for their constantly source of encouragement to do new things instead of always they encourage and they discuss and they help and they both of them in anything I can approach and I can discuss with them. Always I'm very thankful for their help in my work in cornea. So today coming to my topic, the share it's good only, no? We are able to see. Yeah, the cornea and clinical practice. It's my one of the favorite talks I've given many times, but I don't keep the same talk. I change it. Today I started working so many. It's good, to invited by a renowned faculty. So I will also learn. I will also read and try to make it more presentable than to a small audience. This is my favorite topic because we see so many referral cases, simple cases referred to me from different parts of South India, basically all 3 states I get. So this is my favorite slide. I have shown you many, many times, but I don't find shy showing again. A small corneal abrasion, non-healing abrasion, if you can locate it at the inferior part with pain. This patient actually came from Dubai, treated for 15 days there, and no relief, and patient's a little better, not much. So you see a small abrasion in the lower part, non-healing corneal ulcer diagnosed. Then we just put a fluorescein stain, the conjunctiva and cornea. So whenever what I tell my juniors, my PGs, whenever you do a congenital ulceration continuing onto the corneal, and there's no specific character, there will always be a foreign body opposite to that. So if you carefully see it, there will be this, we call it as caterpillar hair or insect hair. It's a seasonal. Some they release it, somehow they get embedded in the conjunctiva, tarsal conjunctiva, and they keep on rubbing the, producing the trauma to the opposite side. If you carefully see it, we can see them. Sometimes we have to put the vasoconstrictors because the eye is congested. We can't see them, especially when they are translucent or it is a brown color instead of black color. Here we are like a little bit black color. We are able to see sometimes 2 or 3 will be there. They will always be there. Sometimes we can't see. We have to accept that. Sometimes even after careful examination, we can't see them, but they will be there. So it's like that pouting here, and we need a very fine forceps. What we have to remove are just a generally available forceps in the ophthalmic OP for doing some purpose doesn't serve. We need a really good one, like a titanium one surgically we used for corneal surgery to peel off, because they are so fine, so small, to be first one grip, we have to pull it out. It's a very nice forceps we have to catch and we can remove them carefully. It gives relief. Then comes my second the point, the recurrent corneal erosion, which is a common condition, and most of the places, even many inquiries I get from US, what is the treatment? We are suffering so much. I had so many friends, patients became friends after we treated them. So they used to cancel their entire business trips and the shooting schedules by senior directors and actors. They cannot attend the shooting because early morning they get up, they can't open the eye, so they cannot attend. So this is a very serious condition, though it looks like very trivial for us as for ophthalmologist, but it's a serious condition. And in a healed phase, also we can see small translucent area. This is better appreciated with the fluorescent, but without fluorescent also we can see them. We can see these small areas even in healed phase. So better to treat. I go by a small calculation. That is, if a patient had 2 or 3 episodes, I treat them. First 2 episodes, 3 episodes, maybe it's a span of 1 or 2 years, it doesn't matter. 1 episode, I just go conservative management. Second episode, I tell them, maybe you need treatment. If somebody walks into my clinic, I had 3 or 4 times, I strongly suggest them, you have to undergo some treatment. So the treatment options are very simple. We have anti-stromal puncture and a PTK and diamond bar. So these are routinely done by most of the corneal surgeons. It is not a question of surgical, it's a very simple surgical. But how we advise the patient and boldly take it up for surgery. In this video, short video, I'm going to show how loose the epithelium. This is the patient just touch the epithelium, entire epithelium will come out. Sometimes entire cornea, the entire total epithelium will come out. And the diamond bar is one of the cheapest, and if you don't have access to excimer laser, this is the one of the best one. But the only trick here is we have to apply for a quite sufficient time. Just doing one stroke is not enough. We have to really do for 1 or 2 minutes. You have to debride the Bowman's membrane thoroughly, then it works very well. And this is much better than a stromal puncture because it doesn't leave any scar and it looks absolutely perfect with diamond bar.
Dr. Reddy, this diamond burr you will be applying onto the area where recurrence is happening, or you will do the entire cornea?
So most of the times, what I found is in 80% of the times, when I sweep the cornea epithelium, entire epithelium will come out with a dry merocil sponge or cut. Though the area which is breaking down maybe the inferior to the pupil or temporal to the pupil inferiorly, but entire epithelium is loose. So I remove the epithelium, whatever is loose, and do it entire. Most of the time is 90% of the cornea.
Okay. Thank you.
And I shown this video because first, before doing, I searched the entire web for a diamond burr for RCE. I couldn't get it, so that's why I'm showing this video. So otherwise, this is another very condition, very interesting condition is SLK. The pathology and it's not physiology, pathology and geopathology. It's unknown, to be frank, and they say thyroid, and so many in 30 years of my practice, I have not seen a one hyperthyroid case having SLK. Then many of my colleagues, I asked them, corneal practitioners, they said they are not seen it so frequently as given in the books. They also saw it once in a while in a case of thyroid, associated thyroid. But most of the times they are not able to find any reason. The SLK is very typical. We miss it because it's not a slit lamp diagnosis. Basically, we have to see in a broad light, whether it's a daylight or near a window. And most of the clinics I know now in big cities, they don't have windows. So we should have a diffuse light in the room and lift the lids, both the lids, so we can nicely see this finding. So this is not a big job. Then when you avoid the lead, this is the very interesting thing for me. If the patient is having SLK in one eye, the other eye is normal, there will be gross difference between the tarsal conjunctiva from the both eyes. And even if you compare with normal patient, it looks very congested and not much follicles and papillae, more papillae picture. And here comes the pathology. The textbooks and most of things says that pathology is in the conjunctiva, the tarsal is only the consecutive. But I personally believe that pathology is in the tarsal conjunctiva. What we see on the conjunctiva is only the consequence of hyperemic tarsal. So I personally believe, though I cannot prove it, the primary pathology is in the tarsal conjunctiva of the upper lip. Either is subconjunctival inflammation or conjunctival inflammation, somewhere near the tarsus. So my choice of treatment, after I came to that conclusion personally, we started giving Tacrolimus to reduce the inflammation, 0.1%, and supratarsal steroids. First, I started using supratarsal steroids, gives beautiful results. So many of it started about 10 to 12 years back. We never had a failure. 2 to 4 milligrams of triamcinolone we give supratarsally to the tarsal conjunctiva. No topical lubricants, no topical steroids, nothing. One dose of tarsal steroids, supratarsal steroids, and Tacrolimus 0.1% ointment once a day in the night for 1 year or around 18 months. It works wonders in these cases. And this is one of the example where after the application after supratarsal, this is a post-operative picture after 2 months of that tarsal conjunctiva, which is almost coming back to the normal, like a normal person. This is another interesting condition, the adult dysfunctional tear syndrome or ocular discomfort syndrome, where there will be patient who have terrible problems. The conjunctiva we can see loose and hanging around all around at the lower part and sometimes upper part, and forming a fold and producing terrible irritation, pain, and Delamination, like sometimes Delamination. Most of the times it is only irritation and pain and sort of watering. So this is a conjunctival callosis, and it is diagnosed as a condition where there is excessive conjunctival folds. But I personally, after careful examination, I am of the opinion it's not excessive conjunctiva, it is the loss of attachment of conjunctiva to the subconjunctival tissue, especially the fornices. When I observe these patients, the fornix attachment of conjunctiva is almost not there. When you pull the lid, it's prolapse, it's something like a retinoschisis, it's just hanging around conjunctiva everywhere. And so I want to know the panelist opinion, so I put this one. So I want to further explore this idea of fornicel attachments, reforming the attachments for conjunctiva in these elderly patients instead of excising the conjunctiva and forming a deep fornix, and see whether it will help this patient from the conjunctiva balloon loosening and folding up onto the cornea. So I'm talking with my arthroplasty people to take up this work. Then another interesting and very common in our practice is when a small child comes, I always ask them, so how many drops you are using? Please show me. They bring so many drops out of their hand and put it on the table. So these drops, one thing we have to remember, they will have preservatives. Even the drops are not toxic. The preservatives themselves, so many drops applying by one child, they alone is sufficient enough to damage the ocular surface over a period of few months. So these childs will be on that. So we have to remember. So I always advise my students, I prefer to apply not more than 2 drops in this child, because it's very difficult to get a preservative-free steroids or preservative-free antihistamines or anything. So that's a point I would like to emphasize. And if you ever the conjunctiva, you can see when it's look like this, there's no point where to go for supratarsal steroids along with Tacrolimus. Sometimes they will have a shield ulcer. This is another interesting one. How we treat shield ulcer. Then sometimes you see like this, especially when they're using quinolones, especially the first generation ofloxacillin, or in the days of ciprofloxacin is quite common. but with ofloxacillin and fourth generation, now it's much better. So this is a quinolone deposit on the Bowman's membrane. This is not a shield ulcer where there's epithelial defect, because the quinolones are acidic in nature. The tears are alkaline. When you put them, they get precipitated and they get attached irreversibly to the Bowman's membrane. They take some time to go off. There is no point when it's something like in pupil area. There is no point in scraping because it doesn't leave a defect, or it can leave a scar. So coming back to the shield ulcer with a plaque, there are many treatments that are given in the books and recommended and spoken by speakers, like scraping, AMG grafting, keratectomy, superficial keratectomy. But after trying few things, again, my favorite technique for a shield ulcer, a diamond bar looks like is an excellent option, and with a supratarsal triamcinolone, 2 milligrams. This case exactly in the pupil area. I don't want to scrape and spoil and change the shape of the cornea in the pupil area, which will result in a terrible refractive. You don't get a scar, but it's a refractive surface. It becomes a very irregular. So the diamond bar gives a very smooth, very nice surface, and it really gives a good refractive surface post-operative. So coming back to some other cases, this is a very interesting case. We had few cases. A spring-catar treated for a long time, and this is one eye of the patient. No simple limbus cells, and the conjunctivization is going on to center of the cornea. Right now, patient vision is reasonably good. He's having 6/12 unaided through the center. But when the fun is when you look at the other eye. The other eye is terribly vascularized and counting fingers close to face, and he's a 21 years old gentleman pursuing his studies, and all this happened over from the last 6 months of time. So he's right from childhood is one. So it looks like he needs some sort of lamellar graft, but where are the stem cells to epithelialize and prevent further problem? So we took a OCT of this patient. Then we found the cornea below the fibrous planus is really good. The cornea, we can see nice line, and cornea is very smooth. Everything is grown over the cornea. So we decided we just remove that. Why we should go for any corneal surgery? So the plan in this case, it's a 747. So there is a planus, and the healing, we thought, okay, we use a AMG, and for limbus stem cells, we thought, okay, let us slide hollow slit and cadaveric in this patient, and let's see what happens. So this is a simple surgical technique, and slit is nothing great about that. And what is interesting in this case is the fibrous attachments are, some areas it is quite dense, and some areas it is not that dense. So we are able to separate and form a plane with a smooth, reasonably smooth cornea. Then, as usual, we did a AMG with a tucking, and we took a select from a good cadaver eye where there is a lot of nicely seen palisades in the limbus, and we took plenty of tissue, not 3 millimeters. Almost I took more than 260 to 80 degrees, and we kept them all over. This is untraditional. Traditionally for slit is recommended 3 to 5 millimeters of area because it's so much defective with that, because we got a tissue also in hand and applied and see. The patient has not received any systemic steroids, only topical tacrolimus and steroids. And this is what happened. And this is the 2 months, this is the 1 year, and this is 2 years after presentation. He's doing very well. Vision has improved to around 6/12 and refractable to around 6/9, and it keeps going on very well. Then comes the another outpatient patient where they have conjunctivitis, the adenoviral. Now we know that not only adenoviral, enterovirus also can produce conjunctivitis. Almost 30% of cases of enteroviral conjunctivitis now epidemic in India. So this is the microsporidial conjunctivitis, keratoconjunctivitis. This is one is emerged as one of the recently as the one of the main causes of epidemic keratoconjunctivitis. How do you differentiate clinically with the least diagnostic capacity? I mean, available techniques with the microsporidial. What we found is in microspadial conjunctivitis, the speaker looks like they are just painted there. There won't be any surrounding corneal inflammation or reaction in the early stage. They just looks like they are kept there. They're just kept there as a white spot, and the cornea will be crystal clear everywhere. They are only as a dots. They are just painted over that. So this gives a clue that mostly we are dealing with microspadial keratoconjunctivitis. So when this one becomes, when viral ones becomes bad, and it develops Bowman's membrane or inflammation at sub-Bowman's membrane, there's a stroma layer. We call it as like this is quite common. They almost one epidemic, sometimes 100%. Some ophthalmologists, even my colleagues, PGs, all they got it. So when you leave it, they become worse like that. They are very difficult to treat. So previously, we used to give a lot of steroids and very difficult to taper steroids in these cases. Once you start them, once you reduce them, they get a rebound inflammation. So here also the Tacrolimus, the magic drug, came to our rescue. So right now we are starting even first few days, even this you see it after a week, we are starting on Tacrolimus. They are responding very well. The response is very dramatic in early cases. And the only thing is we need to continue for 2 to 3 months. It doesn't matter because it doesn't raise intraocular pressure or anything. The Tacrolimus, we can continue for a few months. We have to continue to give a very good relief to these patients. So nowadays, rarely we are using steroids in this patients. Another interesting case is this case is post-operative bonds. So this is a nutritional deficiency. Basically, the post-operative post-cataract surgery, they lose the vision and the cornea becomes very irregular. So this is a general diagnosis I saw is viral keratitis, and they give antiviral. So this further compounds the picture. So all they need is a nutritional supplements, and sometimes we just block the lower punctum, one punctum, to make the tears more, to block the punctum with a catgut. Small catgut we cut for 3 millimeters in size, which is easily available, very cheap. This is a 40 catgut. We cut it and we push into the canal place, not in the punctum, we push it into the canal place. So it will get dissolved over a period of 3 to 4 weeks. So by the time the lesion becomes normal. But these patients, they need a lot of topical, the systemic vitamins and nutritional supplements. That's what we found helping. And we see in young people, a lusterless cornea, a featureless cornea. So they come with a vague discomfort and a loss of vision. This we found in children. It's a congenital anesthetic cornea. Most of the places it's treated as a viral keratitis because there are no sensations, and a ulcer that's more sometimes looks like epithelium, a geographic ulcer. So instead of congenital, so antivirals will only complicate the picture and worsen the picture. These cases are very difficult to treat. We used to do bilateral torsography and leave a small central portion in children in this, but now the sural nerve transplant, they're saying it's helping them. So though we are not done in our place, but in our institute in Bangalore, they did fewer cases, and they're saying the results are quite satisfying with the sural nerve transplantation at this point. This is another interesting one, the cornea. There's a superior vascularization, and we don't know the etiology or etiopathogenesis. This is not SLK. The congenital will be reasonably okay. But this one somehow responds to tacrolimus better than steroids. They really have long course. And the same thing comes inferiorly. This is when I discuss with a lot of my colleagues, they say there are two. One is chronic blepharokeratoconjunctivitis, or it can be adult inclusion conjunctivitis. Though it's not diagnosed like that. But what we found, this is quite common condition we saw both in children and young adults, not mature adults, very young adults like 20 years, or very small children, 6 to 15 years old. This somehow with all combinations we found azithromycin topical drops and oral azithromycin cyclical therapy. Once in a month we give 1 gram, or once in 3 weeks 1 gram azithromycin for 6 months to 1 year, and topical azithromycin drops once a day for 3 months. Almost all the conditions will resolve. But most of the times, these kids will be receiving the steroids, which is not helpful. and which just symptomatically gives relief, but no pathology relief. And a bee sting. A bee sting is a emergency. It looks very bad with hypopion, so we suspect a bad infiltrative. Actually, it is a reactive hypopion. The sting somehow has to be removed. Many times it's very difficult to remove. It passes into antechamber. Few times we made a paracentesis removed from the posterior surface of the cornea because it is better penetrating there than in anteriorly. So we have to carefully see for it. Now OCT helps. And once we remove and treat them along with steroids, that's the main thing. Along with antibiotic, we have to give a lot of steroids for them. They dissolve very well, become normal. If we leave the sting, they go for corneal decompensation, irreversible corneal decompensation. Then the traumatic lens injury. The eye is quiet. It's not endophthalmitis. There's no edema, no chemosis, nothing. But you can see an abscess here on the cornea. So treating with topical antibiotics, systemic antibiotics is not of much benefit in this case. So this is quite common in rural India. I don't know about the cities where the farmers go for field, the thorn pricks, and after a few months they come like this, applying some moxifloxacin drops. The surgery is the best option with them with intracameral antibiotic. It works well. So many cases we did, and none of the times it spread the infection. It is always controlled. It's only a question of reaction, post-operative inflammation. It takes some time to sleep, but ultimately they do very well, these patients. And another, this one we found is a case of fungal ulcer came recently with aspergillus, and we started on anatomized drops, and it healed very well superficially. But there is some amount of reactivation in the pain and vision and the patient symptoms, and it started growing on the posterior surface. So OCT is a wonderful instrument. We found it's very useful now, even in corneal ulcer. When you take a OCT, we can see the bumps in the posterior corneal surface elevated. The anti-surface healed very well. That's a big problem because the natamycin cannot penetrate. Now the epithelium is covered, the nothing, the antifungals will not penetrate. And the amphotericin B intracameral dose helped a lot in these cases. But the only thing is we found is one dose is not good enough. Every 72 hours, we repeat 3 to 4 doses in these cases where we see a posterior corneal spread of the fungal. It resolves very well. The cornea becomes, we can save the patient from a therapeutic corneal cluster. And of recent, we started this rose Bengal photodynamic therapy for corneal ulcers, infectious keratitis. The articles are there for a long time in literature from 2015 onwards. They are trying. Dr. Amiscu, as you know, he has presented many times, even recently, about this one in the webinars. So the known about this technique is the rose Bengal doesn't penetrate more than 200, 300 microns. So any superficial corneal ulcer is a potential to get cured. But if it's more than 300 microns thickness, it's unlikely to get cured. That's we need to. That is the science. That's we have to remember. So we started using 0.15% rose Bengal instead of 0.1 as recommended. 30 to 40 minutes we apply rose Bengal, debride little bit epithelium, and apply instead of 5.4 joules, we are applying almost 8.1 joules. We are applying for a short period of time. That's around 4 minutes of time. We are running 530 to 1. The ideal one is 540 to 560 because we are getting only 530, 560. We are using that one. That is okay for that wavelength. And the results are quite encouraging in superficial. So this is a young patient, 24 years, with a spreading fungal ulcer. It was referred after applying natamycin. The ulcer is spreading out superficially and enlarging. That's how they referred it. So we didn't change any treatment. He was getting natamycin. We continued natamycin, and we did a rose Bengal PDT. This is the result after 1 week. It's dramatically healed. And this is another case. The fungal ulcer, it's a started treatment in our place after a week. It started a small lesion and it started spreading. So we did a RBPDT. Within 4 days, this is the 4th day picture, almost 80% of the ulcer is healed. This is a recurrent viral keratitis in an elderly person. He's getting once in a while, once in 3 months, 4 months, the cornea is totally going for a scarring and a non-healing ulcer. So we did in this case, and it's also responded well. So here we need to remember one thing is this works only for superficial ulcers. If I go for a study protocol, something like that, they give a non-healing ulcer and deep ulcers, it doesn't work. You get a negative results. That's where the problem with the studies with the double blind or. So coming to the antibiotic prophylaxis and cataract surgery, we had a peculiar problem in South India in our non-paying charity work. The nocardial, we don't call it endophthalmitis, nocardial infiltrates in the anterior chamber, and vitreous will be good and it will be clear initially, and it takes a prolonged course. If you get 2 or 3 patients per month, one patient, that's okay, that's your kill. You will have always 2 patients in the ward sitting for a few months. It runs for a few months and very resistant to treatment. Whatever you give it, 80% will go for blindness. So this was going on for a long time. So we were thinking, and working on that. We did AC ducts, checked the ducts, and collected all material from the ducts and grown cultures, nails, toenails, and eyebrows, eyelashes. Everywhere we collected, nothing. We are able to come to a conclusion with this nocardia, source of nocardia. Then we started mixing amic acid in the BSS. Let us see what happened. So our dose is 0.1 ml of 12.5 milligrams of in 500 ml. That comes to 50 milligrams for 1 liter. That is 25 micrograms per ml. This is well double the level of MLCR MPC, which is for nocardia, which is usually around 6 to 8 micrograms per ml. We had a dramatic result. So there is a 10 times reduction in incidence. So over a period of 5 years, we are practicing this. So the incidence dropped from 18 to, out of 40,000 cases we operate, we used to get somewhere endophthalmitis in 18 to 22 cases variable per year. So within this, 45% are nocardia. But the overall incidence now we are getting 2 to 3 cases per year out of 40,000 cases. So this has helped us a lot in reducing our endophthalmitis further almost to zero level. And the DALK is a very good technique, but the still problem is astigmatism. So to control that, we developed a catoscope, which we attached to the microscope and used during surgery. But that's okay, that's fine. But post-operatively, what we do, we found this is very helpful. So we put on the patient and topical drops, and they look straight into the light. So we relax the incisions, because it's only DALK. It's not PKP, it's not thrown through surgery. So wherever there is a steepening, that area alone we can do it. We can selectively do, for example, these cases you see it, we are done in the upper nasal and upper temporal area. There is some irregular scarring and irregularity of the gum. And we put a one small stage suture. And we try to see this by relaxing the incision, and we to see this, the light comes nice round. And this bringing down the astigmatism to around less than 2 diopters. So the 2 diopters is okay, that easily we can either manage with spectacles or we can do some refractive surgery. So the end stage disease is one, which is always a puzzle. What to do? This is actually Boston type 2 is recommended. So especially the cases like this, the standard recommendation is Boston type 2 through the lid, and the results are not very encouraging for Boston type 2. What nowadays most of us are doing, and we started doing a long time back, is a Boston type 1 with MMG grafting in these cases, through and through. All the microscope, all the ocular surface is covered by buccal mucous membrane. Surprisingly, they are doing very well. Even 5 to 7 years survival rates is comparable, even better than the osteogenetic keratoconus. Cosmetically also very encouraging, and it's a very simple surgery. It takes around 1.5 or 2 hours and single sitting. This is another very encouraging one. You don't need to go for 2 to 3 sittings. And post-operative follow-up also can be done by a local surgeon. A person who is not trained in keratoconus also can follow up these patients post-operatively for the long distance patients. So these are some of the cases. with buccal mucous membrane grafting and Boston type 1 cataprocess. So what a desire to develop a new techniques, as Dr. Professor Jeevan sir has shown. So there is there in the mind. So we developed a titanium for cataprocess, and in fact, 10 years, 12 years back, we patented a titanium skirt for cataprocess, and we implanted. They are doing well, but we had a lot of problems. We post-operatively we found. We are of the opinion that a rigid backplate is not a good idea for a cataprocess. That's our conclusion from our results and our study of this cation in 10 cases. So that's one. But in the Boston K-Pro also, the backplate is rigid. They had initially PMMA, but now they are also using titanium. So they came back to our model, which we started 15 years back, as known these results of titanium cataprocess. So we developed a hydrophobic acrylic soft flexible backplate for cataprocess. This entirely new cataprocess after 10 years of work. We now final design has come and this is ready for implantation now. We have a front plate and back plate and central stem. This is a front plate going on. When the final model comes, front plate will be already fixed to cataprocess. The front plate is also flexible hydrophobic acrylic material, and in the center there will be PMMA stem, and this is the corneal tissue going on. This is a lab testing of the cataprocess we are doing, and I can have this one on a iBank eye, and this is a back plate. This is a black plate right now is 8.5 mm. Now we are reducing to 7.5 mm, and this is the entire one assembled, and we put an artificial chamber, and it looks very nice for us. And we took a OCT to see the gaps all up nicely filled. There are no gaps. And what we did in this case, it looks really fantastic for me. I don't know, but and another thing is we can use this one to. You don't need to a corneal tissue if the already bullous keratopathy something is there, recurrent failed graft. With the same graft, we can with the same cornea. You don't need to do a grafting and suturing. We can do a sutureless keratoplasty with a temporal SSCS section. That is the advantage of this new keratoplasty. And we tested in the laboratory. We connected to a digital pressure sensor and increased the intraocular, the artificial antechamber pressure with a syringe and injecting air and fluid, and up to 500 millimeters of mercury, there is no leakage of air or fluid. What I read, what I remember in Boston, usually 100, 150 millimeters, after that it starts leaking. So we are able to, in this model, up to 400, 500 millimeters, there is no release of backplate, and there is no leakage of the air or the fluid. So this is ready for go. We are not implanting humans now. Maybe in a few months or a year time next year, we will be starting implanting. Thank you very much for this opportunity, and I thank once again.
That was mind blowing. That was truly mind blowing. An excellent presentation. I must say that. Without. So much of learning from your presentation, and we are extremely, thankful to you for, sparing your valuable time. First, we would request the two panelists, Dr. Amit Gupta and Dr. Shakeen Singh, to say something on the talk as well as, give their inputs. Dr. Amit?
Good evening.
Yeah, good evening.
So I'm really sorry. I've just joined a few minutes back.
Okay.
So I was stuck up with the OT. Please pardon me for that. But the last moment I've seen is the modified K-Pro. I find this is a very useful instrument for the patients we receive in the northern part of India. Because most of our patients, they are vascularized cornea, and it's a really compromised ocular surface. I look forward for using this K-Pro, new K-Pro, and I hope this would help us in a long way. I cannot comment on anything else, but it's been a very good talk. I'm really sorry I was a bit late to join. I was stuck up in the OT.
Dr. Amit? You're mute, Amit. You have to unmute.
Yeah.
Yeah.
Hello. Sorry.
Yeah.
Dr. Reddy, I think it was absolutely remarkable, the cases which you have shown. And one which you showed was the low dose triamcinolone. You used 2 to 4 milligrams of triamcinolone. I mean, do you do that often? And do you use it often in BKC patients as well?
Yes, it's routinely. It's not unusual. We are little bit use it. Maybe you can call little excessive use. Once there is a severe stage or moderate to severe stage of VKC, even the first visits itself, we use triamcinolone. We tried a lot of things. 2 to 4 milligrams we found very useful. That's more than enough for.
So
10 milligrams.
This is much lesser than what is actually, what we see in literature.
So, see, actually, I searched literature 15, 20 years back when we start using this. Literature has not mentioned what is the dosage of exact triamcinolone supratarsally. They say 0.1 ml, 0.2 ml of what dose, what strength, and they are not mentioned. So that is the big lacune. So when they go and write triamcinolone, they give 40 milligrams, use 0.1 ml. So the usual available is 10 milligrams and 40 milligrams. 20 milligrams was there, but now not available that readily. So the 10 milligrams, you use 0.1 ml, it comes 2 milligrams. And if you use from 40 milligrams, it becomes 10 times more, 20 milligrams. So
fantastic. Dr. Reddy, you also talked about the use of azithromycin, a single drop a day for 6 months and oral. Could you just elaborate on the indications once more? I think our viewers will be very interested in that.
That's the case. We saw peculiar cases which are referred to our cornea clinic initial days when I started doing exclusive cornea clinic. Young children with only inferior vascularization of the cornea with congestion in the lower fornix and lower tarsal conjunctiva also a little bit congested and hyperemic with papillae. So these are typical findings. It can be one eye or it can be to some extent on the other eye. So they already might have used some steroids, tried topical steroids, a combination of antibiotic steroids, and they referred. So I am also not confused initially. So I sent for histopathology, nothing was found. Then after searching all literature, somewhere it was. So we started using azithromycin drops and oral azithromycin once in 3 weeks. 1 gram on a single day, because the azithromycin is supposed to last for up to 3 weeks, a dosage of in the glands and everywhere. That's how they treat even the acne, rosacea, acne for dermatologists. So it worked very well. So after seeing these cases, we made it a standard one and keep on presenting in every conference. When you have a case like that, don't put steroids, start this one. And 100% it works, but only we had to wait for 2 to 3 months.
One related disease entity in children is that childhood folliculosis. We see children with moderate to sometimes severe follicles in the inferior fornix. Do you use something like that to treat it?
If it is associated with vascularization of the cornea and photophobia, yes, I still prefer. It works. It works. Not prefer. That's what we found. What you are telling is exactly correct. How do you name this condition is the problem. So one of my very good friend, Dr. Srinivas K. Rao, when I discussed with him, he said, no. Most of these are inclusion conjunctivitis, adult inclusion conjunctivitis, very difficult to prove. Histopathology, biopsy, and all. Just treat with azithromycin, it works. He was also saying that. So this how do you name it? So the same thing when we discussed in Singapore and Hong Kong cases, they presented, they called them as chronic blepharokeratoconjunctivitis. So same picture they are shown and say it is blepharokeratoconjunctivitis and you have to use prolonged lid hygienic methods and topical antibiotics.
Does it help in recurrent chalazion, which is seen in children? We get children with recurrent lesion as well, some kind of a.
But you want to treat recurrent lesion. Usually we don't want, because let them develop some resistance. You keep on keep killing them, they may not develop resistance. I encourage the patients when they call, they explain everything about immunology. You want them a good immunity in their adult life, or you want a person without any immunity like a HIV patient. So they say no, we want good strong white child. Okay, let the lesion cardiolum come. So nobody said no so far. So I don't want to prevent a disease. I want to.
Right. Is that you were talking about the allo sled, the cadaveric allo sled. So what kind of immunosuppression do you give? I mean, surgically, it is, I think, fairly simple to do. The challenge is to keep it going. And how do you immunosuppress these patients?
Yeah, actually, we didn't immunosuppress. To be frank, in this case, what we are given is only topical tacrolimus. Still is continuing after 2 years, once a day. And apart from steroids, for topical steroids for 4 months in a tapering, 4 to 6 months tapering dose, reducing once a day loteprednol. And we didn't give any systemic immunosuppression apart from for a week we gave systemic oral steroids for a week. That's all. Because I cannot sustain immunosuppression for a long time. So I thought, let us see what happens without. But luckily it recovered. It may not be that surviving. It might have produced at environment, the slit where the residual cells of patient own might have been working back. So we don't know, but somehow it worked. And so this is a very good thing we can try.
Well, thank you very much, Dr. Reddy. It was absolutely fantastic listening to you.
Thanks, Dr. Amit. You took away a couple of questions of mine, which I had to ask. So it was very nice. I'll request our President Sir, Professor Tyal Sir, and Dr. Rishi to, say something.
Thanks, Rajesh. I greatly enjoyed that talk, JK. I really had a very good collection of and a diverse, description as well as an overview of so many things in cornea, which and you documented well, and you're able to deliver it so well. I'm grateful to you. In fact, I enjoyed the way you used the burr on the cornea, and I could also see that you avoided the central zone. Now, in an RCE, especially if the central zone is involved, would you venture into that area?
Yes, definitely. Yes, and nothing problem, no problems. We do that.
So it doesn't leave you with a superficial stromal kind of a thing. That's interesting, because we've always tried to avoid the pupillary zone when using the burr, and so that was a very good observation. So I had a good time, and I enjoyed your presentation very much, and I thank you for giving us this masterclass. Thank you so much.
Tyal Sir.
Yeah, it was an absolute delight to listen to JK again. And whenever I have seen him physically, like, it's not that what he's saying, he's always so enthusiastic and with a lot of energy, and that passes on to other person also to do something extra and come out with some innovations. And I think whatever you have shown, the way you manage these difficult scenarios would be definitely people have to see that how we have to think on these chronic cases. I think most difficult cases are chronicity of these mild-looking disorders in the ocular surface, cornea, conjunctiva. Sometimes they look such a minor thing, but patients' suffering is so much. And JK has nicely taken us to those areas. And in fact, I only saw a patient today only with recurrent corneal erosion post dog paw injury into the cornea, and that poor girl who is a pilot herself having so much of problem, and she doesn't want to undergo, laser treatment PTK because that's going to cause some sort of a scarring. And I was thinking of, diamond burr in that lady. The only consideration was, again, I was discussing with her, I'm not sure how much haze would come up with laser compared to diamond burr. So she was willing to, undergo diamond burr removal of epithelium and little bit of rubbing onto the basement area. So that's a good innovative thing, I think we need to have a large series of cases where we can compare PTK versus diamond burr. But unfortunately, you don't diagnose these cases that often to have a larger series of cases. But it will be very interesting to...
Can I just say something, Jeevan? So there is I heard Dr. Dua's talk about alcohol delamination and the comparison with PTK and with the fairly comparable results. So actually the key is probably to remove the epithelium in its entirety along with its basement membrane. Whether roughening the superficial stroma will make a difference to the attachment, reattachment success, I'm not sure if that has been defined. So we routinely do alcohol delaminations or just remove the epithelium and just do a debridement without even doing an alcohol delamination. So what I think jury is still open on this.
I tried it. Dr. Rishi is a very good point. I heard Dr. Dua's talk this one in Bahrain, not Bahrain, in Abu Dhabi, in the WOC. So I tried this technique. It didn't work in my patients. I tried 3-4 patients, and all of them again. I used diamond burr. It didn't work that well. It's okay for a few months. And when I read his article again and again, he is saying that 2 to 3 years they are symptom free again. That's okay. Then we can do it. But this diamond or PTK gives lifelong as far as 4 years, 5 years.
Yeah.
Only diamond burr, it doesn't give any scar. No refractive. What I found is the difference between diamond burr and PTK. Whatever PTK carefully we do it, still we are getting some refractive change. Small amount of refractive, small cylinder is adding, or aberrations are picking up, increasing. Patient says slight drop of vision from the preoperative level. With a diamond burr, nothing. It's zero. They're perfectly all right.
Actually, yes.
Very interesting, that use of diamond burr in a different situations. Like that was very interesting to see using in a that post PKC shield ulcer, which I never thought of. Normally we'll either put them in a long-term steroid, try to take out that sort of a plaque which is over the area. So that's a good innovative way of thinking. Great.
I think regarding alcohol delamination, I have also got a reasonable experience on that. What I felt that Dr. Dua had told, in his presentation also when he had come for the ESCRS conference, and he told that it is very much comparable to PTK. I have a little doubt on that because in my patients also, 2 years is a very long period. Even after 2 months, the patients started developing all those symptoms, and and I have done a lot of PTKs as well. I felt that PTK perhaps is more effective than alcohol delamination in these cases. That is one. I have a couple of questions for you, Dr. Reddy. You presented about microsporidia keratitis. What is your experience on epithelial debridement in these cases?
We are not done. We are just giving fluconazole eye drops. That's all, as recommended by my boss, Dr. MS, who's my teacher. Fluconazole. But the trick, what we saw is, if you apply even fluconazole 6-10 times a day like that, it's a terrible toxicity ocular surface. Just 3 or 4 times a day, that's fine. The minimal drops usage is we found is more useful in the adenoviral conjunctivitis than using 10 times a day, 6 times a day. Always they land up very bad. If you apply even antibiotic 2 to 3 times a day, that's helpful.
Yeah.
You are doing that. You're doing anything. debridement for microsporidial severe cases?
I have done in 3 patients, and I gave fluoroquinolone after that, moxifloxacin after debriding, and they worked well actually. So I have experience of only 3 patients like that. But then only fluoroquinolone also I have used, and they have also done well. Without debridement. So that is why recently had microsporidial keratitis in one of my relatives, very close relative, and then I just gave fluoroquinolone and it worked in that. So I'm not very sure about debride, we should not. That is one. The other thing I just wanted to know from you was in nummular infiltrates, you have used Tacrolimus and the results are very good. I could see the post-op pictures. So what is the frequency of Tacrolimus in?
So if it's a severe, if it is really severe and it came patient come after 3 or 4 months after steroid use and everything referred or something like that, unhappy treatment patient, then we give twice a day, 0.1%. Early morning, but there's a problem. Once they apply that, the entire day it will be irritating. So we tell them early in the morning, as soon as you get up, you have to apply. So by the time you take bath and everything, it's okay, you'll be fine. And night while going. If it is mild, just you are starting your own patients on the first attempt within 15 days or 1 week, once a day is good enough in the night.
So do you think Tacrolimus is superior to Cyclosporine in?
Yes, definitely. So previously, as Dr. Rishi, as you are telling, mild cases we used to give Cyclosporine, severe cases we give Tacrolimus, but the results are so good, so we shifted 100%. I shifted 100% to Tacrolimus.
I've also used both cyclosporine as well as tacrolimus in these cases. I felt tacrolimus in initial part, cyclosporine doesn't help much. You have to take help of steroid only to resolve this. But tacrolimus helps in resolving these infiltrates also. Only plus point to cyclosporine is that you can use it on long term. Tacrolimus, it is difficult to use it on long term. More people complain of irritation than with cyclosporine.
Cyclosporine is a bit comfortable to go with.
Yeah. Regarding, you had shown one very nice case of the wound infection, phaco wound infection, right? Which was nocardia.
Yes. Actually, yeah.
Some of these cases, they show waxing and waning pattern. Have you noted while treating these patients?
That specifically, that I'm not very much sure, but it goes for a prolonged course. Initially, I used to treat personally, even few cases I did a yanking of the iris, which is, nobody, so because there's so many nodules here and there. First, we started doing cutting with vitrectomy cutter and remove that portion of the iris where there is a nodule, because I assume that Pocada is within the iris. There is no way you can wash it out. Then we start, okay, let us remove it and take a vitreous cutter and cut off the iris. Then it's multiple nodule. Even I remade it in an area, but still it is very terrible to treat and cure this disease. So that waxing and waning, I didn't observe, maybe not very, because I am attending once in a while as opinion person. Maybe I missed it.
I also noted in just a couple of cases, that's why, because we don't get such cases very often. So that's why I thought maybe. Any other comment or question from any of the panelists? Okay, Tityasa, would you like to sum up?
Just one more query. Jacob, in your new design of K-Pro, do you think that retrocorneal formation will be less in this material? Because
sir, not sure, sir, because the hydrophobic material, hydrophobic acrylic, has got a tackiness. It will attract, it will make the epithelium to stick. But the same property is there for titanium also. The titanium dental implants, that's where we got the idea. They put a titanium which will get integrated with the bone, or that they put the permanent dental implants. So that's where we got the idea for the first titanium. But what we found is the hydrophobic acrylic, Main thing is flexible. It's a soft, flexible material. And if you observe the cylinder design, the PMA cylinder design, we have given a tapering. So whatever the size of the donor, if the size of the donor is 450 microns, 550 microns, it doesn't matter because it will slide and it will get adjusted to that. Whereas in the Boston K-Pro, in our K-Pro, whatever K-Pro now available, it is fixed. The 1 mm is fixed, from 500 microns is fixed. So if the donor cornea is 450 microns, then you have a gap. If it is if it becomes thinner post-operative, there is a gap. Here, that issue is not there. So this took a lot of time thinking. Almost, I'm telling for whatever little time left behind, we think in the night when you don't get sleep. So ultimately, we got that idea. So we just give a tapering. It looks very simple. But it's working now.
Good. Let's hope we have a good clinical outcome of your design also.
I'm expecting very well.
Truly, it was a master class today, and especially looking into, as I said, common, most chronic recurrent disorders, very nicely depicted, and new sort of innovative management of these cases are required. Basically, these patients will go, as you showed in one of the slides, multiple drops for one particular person. That is true for, we see these patients every day. They carry, at least 6, 7, you can say, bottles, container, those packets. Sometimes they just carry the packets, these are drops we have used in our folders. And these patients do require innovative thinking from our sides also. But it was great listening to you, J.K., and hope that we'll have much more such talks from your side. Thank you again.
Thank you.
And thank you, entire panel. The discussion was really good.
So in the end, I would like to thank Dr. J.K. Reddy and all the panelists and all the office bearers of ISCRES for participating in this webinar. I would like to thank the IT team of Mr. Bageshwar and the staff Anil Kumar for being there. So thank you all and a very good night to all of you.
Thank you, Dr. Rajesh, Dr. Chal. Thank you. It was wonderful being on the session. Thank you so much.
Bye.
Thanks from my side, Dr. Tatyal sir, Dr. Rishi sir, and Dr. Rajesh sir. I'm really sorry. I was stuck up in some emergency, so I was a bit late to join. Thank you so much.
Thank you, sir.
Good night.
Thank you.
You must have covered up in the discussion part only, because discussion also had all those points.
It's more important. The crux of this I'm able to take away.
Okay.
Thank you, sir. Thank you.
Okay. Thank you and good night to all of you.